Tēnā koutou katoa, ko Yuptilich tuk winwa, ke te mahi o Aotearoa ai ho. Tēnā koutou, tēnā koutou, tēnā katoa. Welcome from New Zealand. My accent might not give it away, but I live there and work there these days, originally from the Netherlands. Content warning, there will be COVID stories here, but we'll keep them brief and interesting. And then I'll talk a bit about how we're trying to leverage those technologies that we've built in over COVID and how we're now trying to use them for other public health questions. Other warning is that some of the results that will be presented here are only possible when you have got a committed government that is taking a science policy, so we cannot guarantee that this will work in your setting. So at the institute where I work, genomics is used for a wide range of types of experiments. So it ranges from public health, but also border protection in terms of looking at what is coming across the borders, all the way to water and environment, in terms of soil health, food health, and forensics purposes. I'll be focusing on the public health side of things, but just so that you have a bit of an idea of where we come from. There's the COVID-19 pandemic and what we did in sort of 5 brief acts. And the first thing is that we were incredibly grateful for the Arctic Consortium when they put out those primers, and Josh Quick said on Twitter, like, if you need an aliquot of these things, put up your hand. And we were one of the people to put up our hand, and when the first case of COVID came across New Zealand's borders, we could immediately start sequencing that and start looking at where it had come from and what we could learn from it. The other thing that we were very grateful for that is within New Zealand we also had people at Massey University, Olin Solander and Nikki Frieden specifically, who actually created a Midnight protocol based on the Arctic learnings, but making those amplicons slightly longer so that you don't need to replace them as often and so that you can have a slightly cheaper and faster protocol. So that meant that we really started to push that real-time angle. New Zealand was taking quite a severe approach, and our ambition was to sequence every single sample in a real-time manner. And there was a lovely paper out by our Australian colleagues showing that you can definitely do this. You can get the same results with Illumina as you can get with Nanopore. The difference is that one is days and the other is hours. So we really focused on the eradication and keeping it out. And New Zealand locked down very quickly and very strongly, and it meant that every single case mattered. We had discussions with local public health units about whether someone had contracted it in the elevator or in the laundry room. It was like forensics level of analysis of where something had slipped through the nets that New Zealand was putting in place. And one of the other things that we did is because there were so many different units and different people interested in it, we focused also strongly on how we communicate these results. So MicroReact is another tool from a UK outfit that we actually were able to use quite efficiently to communicate these results in a similar real-time fashion. So there were daily updates to that interface. Now, the first thing that we did was also starting to learn about the virus. And one of the things that early on wasn't quite clear is how it was transmitting and where it was transmitting. But because we had this quarantine system, everyone needed to get a test when they entered the country. And we saw that there were these people that had highly similar genomes, but they had come from all across the planet. And when we then looked a bit further, we actually saw that they were seated in a very particular flight pattern. They were all in the same area, and the people that were slightly further away were all negative. And also, if we looked at disease progression and international genomes, it became quite evident that these blue people, the A and B cases, must have transmitted this on the airplane. Now, that was not the first story about there might have been airborne transmission, but it was definitely important because there was at the same time that American authorities were putting out that getting COVID on a plane was impossible, and we showed you could. There was another one that was really the nail in the proverbial coffin of COVID being airborne, and that's this particular group of people came into New Zealand. There was one person that traveled by themselves, and there was a group of people that traveled as a family and that stayed into the room. Now, from an epidemiological point of view, you see a group of people coming in, one person is positive on arrival, and then the others become positive. The very logical assumption to make is that that additional person infected the rest of their family. However, genomics told a slightly different story. They had genomes that were completely different from that index case, and they were actually similar to the person that was living across the hall from them. And that person, there's CCTV revealed footage that there was actually transmission across the hallway. These people never left their rooms. So there must have been aerosolized transmission, and why we could definitively say that it was aerosolized is because we were lucky enough that the corridors were wider than 2 meters. And that's then when you reach that definition. And that's actually one of the 2 pieces of evidence that made it into guidelines about how we now think about COVID and how it's airborne transmission. And again, was that really sort of real time and every single case being sequenced that allowed us to find these things. The real kicker came when we were able to prevent the lockdown. There was cases that were in Wellington and Auckland, and it wasn't clear how it had spread so quickly from one city to another, because the cases in Auckland were known, but those cases in Wellington, it was unclear. So we were able to process a sample from sample receipt at our institute to an actionable report in 7 hours. This is no longer the world record, but it was still pretty good. But it also meant that we could feedback that this was a contained cluster, and it was actually linked to those cases, so there was no undetected community spread. And the public health measures that were already in place could continue. And it meant that New Zealand did not lock down those cities. Some conservative estimates mean that that easily offset any and all costs that we'd made until that point, several times over. And it was also recognized by the WHO as a way where actually science can prevent lockdowns rather than instigate them. And then we transitioned, as many people had to. Even the New Zealand system was not perfect. It was also not meant to be there forever. But we had vaccination rates that were well above 95%. And Omicron came round. So we started looking at how we can use the genomics in a different way with representative sampling and keeping a finger on the pulse. One of the things that we were able to look at, because we had comprehensive sequencing data from earlier waves, is we could look at reinfections, and we could see which of those new variants were causing more reinfections than the others, because we knew the original variant, and we could sort of contrast those. Globally, we think we did something different than other countries did, because we had that unique approach where we didn't have too many cases, and we could, up until sort of January 22, sequence almost every one of them. So that means that there's certain diversity that we've seen that others might not have seen, because they had to focus on trying to even get 1%, or in the UK 5%. It also means that we now have capacity to do these things at scale. Pre-COVID pandemic, we had 3 MinIONs, and that was it. Now we have 3 GridIONs. So how are we going to use that capacity that we now have to continue to benefit public health? So one recent example was a Salmonella contambo isolates. There were 3 cases across New Zealand, no clear links. But the lab indicated that was a very unusual Salmonella to see for New Zealand. So we expedited those for sequencing, and they came back as linked cases. Then we were able to have some exploration of international data. There were risk factors of tahini in Denmark that were notified for these cases. We were able to compare that to these genomes. They were identical. We were able to then ask questions of these people what they had been eating, and they had all been eating from a similar food box that contained a hummus. And within 4 days, we had a recall of that specific box, and there were no subsequent cases. So that's really sort of showing the real time can also work for bacterials and some of the larger genomes, not just for the small genomes. Another thing that we've been working on is that New Zealand has some bacteria that are quite specific to our country. And one of the things that is really problematic is that there's not always a good reference genome for them, or that it can introduce quite strong biases if you compare to an international reference genome. So what we've started to do is to do long-read local references and putting those in a pangenome. Zoe, who's one of the postdocs in the lab, has just submitted a paper on that we're hoping to show that pangenomes are a real point of utility by now, where they have become to the point where you can start building them and using them for public health purposes. And we did this in Neisseria meningitidis specifically. So one of the things that we see in those pangenome graphs is that if you have those long-read data, you can much better recapitulate those structural variations that you might see, and that actually really improves the mapping rates. So even compared to a matched global reference genome, you do not get the same mapping rates as you get with a pangenome that increases that diversity. And that really means that you can start looking at more SNPs. So if you're doing an outbreak investigation, you have got a wider search space. And it also means that you're reducing your reference bias so that you're actually having more reliable results. The graph that you see there is a graph of 131 genomes, and in the final paper we made a pangenome of more than 1,000 genomes. And you can actually start using your short read data, if you do have that, to layer on top of your long read data and get the benefit from both of those. One last thing that I want to end on is that it takes a big team to get these things done. There were many late night hours, and there's a wide variety of people involved in these efforts that I want to thank. And I also think that's something that we see increasingly in this conference, but also in our work, that we really need to look at the diverse aspects. In New Zealand, it's our indigenous communities, but it's also the different practices, it's the clinicians, it's the doctors, it's the bioinformaticians, and all of that needs to come together if we really want to get the most out of it for the people that we do this for. And thank you for your time and attention.